things. But in doing so, I realized, there's an explosion of information about perimenopause, menopause in the last 3 or 4 years, which really struck my interest. And I wanted to know more about myself. How can I improve my longevity? How can I, improve my own health span and whatnot? And so doing so, I became a member of the Menopause Society, and it became a certified menopause practitioner. So it's a little different. It incorporates cardiovascular health, mental health, sexual health and wellness, bone, muscle health, diet and exercise. So it's kind of more comprehensive. So anyways, when I was looking at the list of lectures you all had, I was like, okay, they got bone health, they got this, they got that. And I said, one of the overlooked topics is sexual health and well-being. I think most, a lot of couples think like, well, 50, 60, it's the end, it's not so important, but it is to a lot of couples, and it's a part of a relationship. And so, anyways, I decided this would be a good thing to talk about. So I made the handouts because a lot of people don't want to raise questions or ask questions or go into specifics. So those are more specific options too, in terms of like lubricants and things like that. But sexual health in women is still very important, perimenopause and menopause. And when I interview women, I'm always surprised that when they say, I go through my checklist of questions and I'll say, well, how is your sexual health? What's your interest? Do you still get aroused or whatnot? And surprisingly, it's always on all women's minds. I feel like the last 20 minutes of a consult I'll spend on just sexual well-being. And I think that, I'm surprised because women will say, well, I have a low libido. That's like the catch-all phrase for a lot of different things. And when I go into questioning, I'm always surprised at what they interpret that means. So for example, I was talking to maybe a 42-year-old, and she said, yeah, we have a low libido, I'm married, happy relationship, great kids, they're 6 and 8, whatever. And I said, so why do you think you have a low libido? She's like, well, we just don't have sex anymore. And then I'll say, well, what's your life like, blah, blah, blah. And then I don't even know why I asked her this. She said, there's just not a lot of room in our bed. And I'm like, what do you mean by that? And she says, because our kids still sleep with us. And I said, okay, so that's not really a low libido, that's lack of opportunity. But a lot of women will just automatically say low libido, especially, I have another gal who said, she and her husband don't have sex very often, maybe once a year. And then when I go in questioning, she said, well, he has difficulty with erection. So I said, well, that's not really, given the opportunity, you might be interested, it sounds like, but it means that we have to work with other things. And so I'm recognizing that low libido isn't necessarily what we define low libido, meaning lack of desire or interest. It's actually a multitude of things that can affect it. I'd say first and foremost, for a perimenopausal, menopausal woman, it's dryness, vaginal dryness, pain with intercourse, irritation. And so, we've long understood that vaginal estrogen, even if women weren't ever considered a candidate for vaginal estrogen due to breast cancer, estrogen receptor positive breast cancer, unfortunately, because it had the word estrogen in it, any vaginal estrogen product, it was lumped into the category of hormone replacement therapy, which is incorrect in that it's not systemic, so it's perfectly safe to administer vaginal estrogen in any patient. And the fact of the matter is the AUA last year recommended all postmenopausal women be on vaginal estrogen if they're not on systemic estrogen, period. And it's mainly to decrease the risk for urinary tract infection, which is the #1 cause of women having to go to the ER, being admitted or hospitalized for sepsis. And so they, black box was removed in July of last year, recognizing that it isn't systemic and it's perfectly safe. And so I find that pain with intercourse is probably the #1 cause that women aren't having sex postmenopausal. But there's a lot of options. Estrogen's an option. They make a testosterone that converts into estrogen as an option. And the way it works is it helps improve collagen, elasticity, blood flow, sensitivity to the area. In addition to, it helps, prevent urinary tract infections. It helps with urgency, frequency, waking up at night. So a lot of other reasons why women should be on vaginal estrogen. That being said, if you're on a systemic estrogen, a lot of times you'll get enough to that specific area, so you don't really need it. But it's perfectly safe in all women, regardless of age, history, and like I say, they're recommending it in women who aren't even sexually active anymore for prevention of UTI. So first of all, that's my first question is, are you having pain? Are you having discomfort? And then the second is, are you sleeping? So sleep is a huge reason why women aren't having intercourse, because if you're not getting sleep, it's the last thing you want to do. It's like, if I get another 30 minutes of sleep, that's it. I'm taking the sleep, an extra half an hour for my 4 hours I'm sleeping, because I'm getting up every morning at 2 a.m. And so, we work on sleep, and we work on, how do we improve that sleep? Be it diet, be it caffeine intake, be it avoiding stimulus, is journaling at night before bed, getting all of that brain noise out onto paper or somewhere else, reading, so I work with a lot of women to use cognitive behavioral insomnia as a therapy for helping them manage sleep. Hormone therapy for those who are candidates can be great options. So progesterone actually converts into allopregnanolone in the brain, which is the same hormone that actually attaches to GABA receptors in the brain that calm ourselves, get us into deeper sleep, help us with more restorative sleep. And so women who are candidates, progesterone therapy, even in your 40s or long before you're truly menopausal, can be very beneficial. So sleep so removing pain, removing discomfort is number one, and then helping with sleep, that's number two. And then, relationships and other stressors, and, exercise is huge. I think it really helps just our overall well-being, but it also helps with, I think just how you feel about yourselves. It helps with energy, and so in relationships. I'm not a therapist, but, I always ask, well, how's it going with your partner? Or do you have any issues? And some women will say, we're in the middle of a divorce or we're separate. And I'm like, well, okay, so that makes sense. But it's not really a low libido. And then finally, when we go through all those different things, cultural, religion, and whatnot, some women just have something called hyposexual desire disorder. And what that means is true lack of desire or interest. And it's only that if it's disturbing or disruptive to you. If you're fine with it, your partner's fine with it, there is no norm for how often you should have sex, or, what's the normal frequency. There is zero norm. So if you and your partner are okay once a year, once a month, whatever, that's fine. That doesn't matter. It doesn't, there is no norm. And so I always ask, if it's bothersome to you and you would like it improved, then yes, that's hyposexual desire disorder. And so that primarily is treated with testosterone. So we do use testosterone therapy. I like it. I've been using it for about 20 years in patients. The issue is there is no FDA product approved in the US for women. And that's been our biggest hurdle. They've tried a couple of times, but it was always shot down. There are a couple products that are approved by their government in Australia, now New Zealand, now Britain, but we just don't have anything low enough. So we've tried to use male products, something like androgel, but the dosing is about 10 times of what I normally will give a woman. Mm-hmm. And so it's really hard to get that low in a male type product. So, because it usually comes in a cream, and I have to say, okay, in that little tube, you got to give yourself 1/10. Okay, that's impossible. It's too variable, and a little can go a long way. And so we usually use compounding pharmacies, and thankfully we have a great one. Actually, this isn't a plug for them, but it's just a couple doors down, but they do a great job. But testosterone in women can be really beneficial. We think it helps with brain interest and arousal, in addition to locally with, just sensitivity, interest, possible orgasm. It also improves with blood flow, not as much with collagen and elasticity, but sensitivity. And it's actually given in a cream form. So I don't recommend giving it orally, and the reason why is that will negatively impact your lipid panel. So it'll make your LDL go up, your HDL go down, which you don't want. And so it has to be monitored. So that's the only thing, is that you want somebody to monitor it probably every 6 months, because we don't have an FDA approved product. There's a little bit more variability even with a great compounding pharmacy. And so it's best to be checked with like every 6 months, because super physiologic levels for women, which is about a level of a 50 or a 60 on a blood test, you can start having negative impact. And what that is facial hair growth, acne, losing hair on the head. So that's why, it's a controlled substance, because of athletes using it for doping for enhancement. And so the interesting thing is they've never really studied, or they've done very few studies in women with testosterone for physical enhancement. So we know it helps with libido, but what about like muscle mass, with energy? They have a few small studies, mostly out of Australia, and the levels that women had to achieve was about 200 nanograms per deciliter, which is, we usually go to 50 to 60. So it's 3 to 4 times our normal range. Those were the women you could see some benefit. We still haven't had enough studies to really pan out to see, is it going to help really with brain health? Is it going to help with any of these other factors that it may? And so I definitely encourage women, if you go that route to using a testosterone product, make sure you have levels checked. I like the cream or the topical forms. I'm always a little more leery of the pellet or injection. And the only reason why is those are all or none phenomena, where meaning that once you get it, it's in your system and it's there, you gotta ride the wave. And I see a lot higher testosterone levels in women who are getting those. It kind of builds over time, and you will feel superhuman. You will feel amazing because your testosterone's going up here, and then you get this big dump and you start losing hair and having all those other physical negative changes that I can't do anything about. I can't reverse them. I can't change. I've seen, women having flattening breasts. I've seen, vaginal dryness and changes. I've seen the clitoris enlarging, voice changes. I can't change that once those physical changes have happened, because those are levels to transition into a man, So I tell patients, it's not that they're bad or horrible, you just have to be really careful about it. Now, there are 2 other products on the market for hyposexual desire disorder, and one is called Addyi and one is called Vyleesi. And they work more on brain chemistry in women. So Addyi, and they were FDA approved for premenopausal women, but we feel like they're perfectly fine in postmenopausal women. And Addyi is a daily pill. You take it night before bed. It lasts about 12 hours. The one caveat is that it can lower your blood pressure a little bit. So women who have super low blood pressure, make sure you're well hydrated. They do have a recommendation to avoid alcohol, and because it's a daily, that's kind of a hard thing for a lot of people to do. But I've never seen any untoward effects with somebody who had a drink, probably 2 or 3 it might, but like anything, that could lower your blood pressure, so you have to be cautious anyways. So that's the biggest downside. But it works on brain chemistry in terms of increasing your dopamine, increasing your norepinephrine, and it's prefrontal cortex, so here in the brain, that helps with mood. So it actually helps with desire and whatnot. What I didn't mention is that some medications also affect desire, and the selective, the SSRIs or SNRIs are the most common, which are a big form of antidepressant that a lot of women are on. Probably 30% of the population, and many of them will decrease sex drive, because how they work is they increase serotonin, but they can drop your dopamine and norepinephrine, so that's how they can affect your sex drive. And so I always tell patients, if they're on something, maybe decreasing dosing, switch to another one, because that can make a big difference. The interesting thing is I've noticed lately is women who are on GLP-1s. So GLP-1s are now out in the market. They're very popular. I think they're great for the right person and good uses. But I have also been noting, because they cause muscle atrophy everywhere in your body, you have to be very cautious. Make sure you have a high protein diet. Make sure you're doing, resistance training, because you will lose even muscle in your pelvis. So I've had some patients say, I don't know what's going on, but it feels different down there. And I, because you actually lose pelvic floor muscle too. In addition to it, because the way a GLP-1 works is not only on brain health, but also on gut, gut motility. So it slows the gut, so that's how it affects your satiety. You have 0 to low motility, and so you're full all the time because you really are full. The secondary way it works is it affects your brain, and it will dampen dopamine, and so you don't get that rush when you see, things that you have an addictive behavior towards, meaning like food. It's now being studied for alcohol. It's now being studied for use in people who have narcotic addictions and other things. But the downside is that sex or interest is also kind of a rush, a dopamine and norepinephrine rush too. So it doesn't happen in all patients, but I'd say about 15% of women and men who are on GLP-1s, they're like, I don't understand what's going on. I feel great about my body. I feel, but I'm just like, meh, and, so sometimes it requires adjustments in their GLP-1 too. But it doesn't prevent you from going on Addy, or flibanserin. So they work a little bit differently, and also being on an SSRI doesn't mean you can't be on Addy or whatnot. But my first recommendation is if you're able to change your antidepressant, because that can make a world of difference. So the last one I have yet to have somebody try. It's called Vyleesi. So it's an injection you have to give yourself on demand, and what that means is that you have to be comfortable giving yourself a shot, which is, it's no more than like an insulin needle, pretty small, in your belly or your thigh. And you have to do it 45 minutes before sex, and it lasts for about 12 hours. But the biggest side effect is high blood pressure, so you can't be on it if you have hypertension. And then the other thing is that it causes pretty significant nausea and vomiting, like 40%. So yeah,
that really turns
it's
me
a hard
on.
sell.
That is
So it's like you got to give yourself a shot, and you have to do it timed, and you could be vomiting all the time. So it's understandably a harder one to sell people, but it works on melanocortin levels, which some peptides and things like that work for that, and it does improve dopamine. But it works great for a couple who have other issues, relationship issues, in that the husband has erectile dysfunction. They do have to do something kind of timed. She doesn't want to take something nightly, so yeah, for that patient, it might work well. So those are kind of the, things or hurdles that we discuss when I talk to men and women. And a lot of times, because I work virtually now, I do virtual consults, I'll have men hop on line too, or their husbands, which is perfectly fine because they're interested and they want to know what's going on, and I don't understand what's going on with my wife, and I still love her and I find her sexy, but is it me? Because men equate love with sex, and we don't. We equate love with, are you helping me with the kids? Did you help me unload the dishwasher? Could you make my cup of coffee? It's so interesting because it's very different, but they just feel like if you love me, you'd want me more or whatever. And it's like, no, it doesn't have anything to do with that. But anyways, it's a pretty short talk because I know you've talked about everything else, and I'm happy and, open to discussing any questions. I'm a board certified OBGYN, and so if you have questions about bone health, brain health, gut health, any of those things, I'm happy to field questions.
What you're saying right now is really true. I have been married for 32 years, and we were very active until my diagnosis. So when it happened, I was straight to him. I was like, "You're super active. I have no desire.
Yeah.
It's painful."
Yeah.
So he was okay with that. Like he has been okay with that, which one I appreciate very much. But also at the same time, I'm like, how do we reconnect again?
Right.
Again is one of the topics that I have asked a lot, but nobody hasn't given me an answer.
Well, I think it's hard because oncologists want to cure you, And once they do, they're like, yay, now you can go. You know, or same thing with surgeons. They've done their job, they've, you know, whatever, done the surgery. They're like so happy because they've cured you and then you go. So I manage a lot of women who are breast cancer survivors who currently have active breast cancer, who've had heart attacks, who've had blood clots, who've stroke, because historically those women were in the category of nope, you absolutely not. And it's really changed and evolved. It's become, I think, much more, there's so much more awareness, and I think we're giving women the authority to make that decision for themselves, you know. But certainly vaginal estrogen is not a danger. It's perfectly safe and fine. It's a good place to start. And I always tell patients, you know, when you start, you know, and I gave you like a list of lubricants, a list of vaginal moisturizers. They're completely non-hormonal, safe. They don't work quite the same way as estrogen, but they're perfectly safe and fine. And I tell patients that, because we don't have a sexual health person, you know, in town. We don't really have a sexual health therapist. But a lot of it is communication and understanding. And I tell patients is to kind of get you to not have pain, because they don't want to hurt you. That's the other thing, is that the minute you wince or something, like, oh my God, you know, we got to stop because I don't want to hurt you, you know, which is wonderful. But at some point, you know, intimacy for a lot of couples is really important, and it's just a connection, you know, it's love. It's just being different and in a relationship that it's special. And so, you know, you can get back to that point. It's just that, you know, it may take a little bit, because when we deal with vaginal changes from lack of estrogen, from, you know, sometimes radiation, chemo, things like that, you have to work with a gynecologist who wants to work with you and is patient and will give you options, you know. For some patients I've had who've had surgery and they have a shortened vagina from radiation or whatever, you know, I'll have them use vaginal dilators, you know, to go slow and just grade up. And you know, in addition to lubricants, vaginal estrogen, all women should be a candidate for vaginal estrogen. Even if you have current breast cancer, you're still a candidate.
Okay, so it's okay.
Still a
because,
candidate.
like, for example, mine is going to be for whatever I'm going to be.
Yep.
I'm going to be on that basic blockers.
Right. You're still a candidate.
Okay.
And they do make a product called Intrarosa, which is technically a testosterone derivative that converts intracellularly to estrogen. Totally safe and fine. That's nightly. Vaginal estrogen is usually twice a week for baseline. But you are still a candidate, no matter what.
So there's still hope.
Oh, absolutely.
Does radiation shorten your vagina?
It can't. Well,
if it's in
well,
that
no,
area.
into the pelvis.
If
To
it's
the
in
pelvis.
that,
Like
in
if you
that
have
area,
bladder
it's not like
cancer.
you're
I had it here,
Or-
so it's not shortening my
Yeah,
vagina.
No, it is, no.
I mean, I
No.
just needed
If it's
clarification. I got stuck on it. Sorry, everybody.
If it's radiation to the pelvis for bladder cancer, or colon cancer,
I got you.
colorectal cancer, yeah, sometimes.
Do you have any recommendations about the vaginal estrogen?
Yeah, so vaginal estrogen, usually if someone has been off hormone therapy for years, meaning it's not just, and they have significant pain, meaning bleeding, it feels like razors, and you know, a lot of women will say that. And I'm like, of course you're not gonna wanna do that. Why would you wanna do that? So it's gotta be nightly for 2 weeks, and it's usually a vaginal suppository, or they have cream, so there's a couple different options. And you use it nightly for 2 weeks, and then you back off as maintenance 2 to 3 times a week, always. And there's Vagifem, which is one product. There is estradiol cream is another product. Like I say, there's Interosa. So there's like 3 or 4 different options. Uvafem is Vagifem. That's the only generic. That's the only one that's generic.
What was it called again?
So you could ask for Vagifem, Vagifem. Yep. And you use it nightly,
So estradiol should be done twice a week?
minimum. Yeah. Well, if some
Up my
women will
dose.
complain like it works too well, that they feel goopy or it's too much, and then just back off to once a week or half the dosing.
What's your opinion on estering?
Yeah, estrogen, so that's a 3-month estrogen
Yeah.
ring. I wouldn't use it to start, because if you're already having pain, something in the vagina, wearing it for 3 months may not feel so good in the beginning. You know, it could be raw or irritating. And so it's this silastic ring that's impregnated with estrogen that's supposed to last for 3 months. You put it in the vagina. Some women don't want to put things in every week, every whatever. You can use it. And so, yeah, it's perfectly fine. The dosing's the same. So the only thing is that estrogen cream, because it comes in an applicator, you can use less or more as you see fit. The Imvexis one, which is a bullet that you put inside, that comes in 2 different dosing. So everything else is like the same dosing. So lots of options. But initially, if it's that uncomfortable, you got to use it nightly. And I tell patients, I'm writing you a prescription, no sex for at least 2 weeks. Because you need to get it to a point of where you're not, like, oh my God. There's a big fear component. And once we have fear, then we cringe, and then our pelvic muscles constrict because we're worried. So I tell patients, always use a lubricant, no matter what, just because it kind of eases things, and then use it for 2 weeks. And sometimes I'm like, just have foreplay, just don't eat nothing in the vagina. It's okay, like until you get more and more comfortable and you don't fear it, because that's a huge factor.
Why do there's so much of lack of education when it comes to all of this, like menopause?
To everything, yes. Well, the WHI study, which was published in 2002, unfortunately misinformed everyone, clinicians, everyone. When I was in training, we were told, if you got to use hormones, okay, but use the bare minimum for the minimum amount of time, and you stop everybody by 60, and that's completely changed. So now we're like, nope, you can start it earlier, not later, because you're going to get the most benefits from it. And meaning cardiovascular, brain health, sarcopenia, muscle, bone health. We have patients start earlier. And breast cancer isn't as big, we're not as fearful of it. And part of it is when you looked at that study and you looked at the women who were in the younger, they actually have lower risk of breast cancer. So we now think, after 2 decades of everybody being off hormone therapy, we realize that, for women who have an estrogen dominant breast cancer, it didn't cause the breast cancer. It promoted its growth once you were on it, but it didn't mutate those cells to cause the breast cancer. The more serious one is triple negative breast cancer. And that has nothing to do with hormones. So those are the ones that are harder to cure, that have a higher recurrence rate, things like that. But I have women who are breast cancer survivors who are estrogen receptor positive, and they're on hormones because they're like, I've got enough, I'm great, I'm cured, I'm 45, I got another 40 years of my life plus, now what do I do? And I'm like, it's your decision. If you had some cell in your body that was estrogen still there, would it giving you estrogen make it grow? Yes. I'm not going to deny that, but you have to weigh the risks and benefits of, how is it helping me against all of these other things? So I look at like women's cholesterol, their calcium CT score, like all the different things, because estrogen lowers your risk for type 2 diabetes, it lowers your LDL, your cardiovascular risk, it decreases your all-cause mortality across the board, it lowers colon cancer. There's so many things that we weren't educated about, so we're just now kind of getting up to speed, like, and certainly diet, exercise, I think taking, certain supplements and stuff like that are definitely beneficial, but for women, estrogen is one thing where to get to help all those different areas, I have to give you 5, 6 things. I have to give you a lot of other things. And so there are obviously other options, and for women who have an active breast cancer being currently treated, we kind of do a workaround. Like, okay, let's work on everything else. And then when you're at your 5 years and cured, let's revisit. Maybe we'll have more data and see.
And what would be a good recommendation for the person, like for me, I'm already in this position where I have to just kind of like educate myself, do whatever is possible for me in order to keep life. But how do we transmit, how do we give our daughters that information? Because like I had Hashimoto disease when I was 30. What will happen? They just give me a pill and that's it. Now when I look back, I was like, maybe if I like put more attention, if I did more research, maybe I could have prevented from the point that I'm sitting right now. But same thing, I have two daughters.
Right.
One of them, same thing, has Hashimoto disease. She was at 14. So now it's like, okay, how do I protect those kids from not like get to 40 and you have breast cancer?
Right. Well, I think, I mean, the studies do show you can decrease your risk. You know, the U.S. has one of the higher rates, probably because our lifestyle, because of processed, and I won't get into all that, processed foods, you know, like not exercising enough, a lot of fast food, poor diet, I think that, that plays a big role. Asians have the lowest rate, and they probably, because and they're not going to the gym or anything, but they're physically active, walking and doing things on a daily basis, So I think it's partly dietary, environmental, and so all you can do is have them exercise, lead a good lifestyle, protect their bones, do all the things that, birth control pills have never shown to cause breast cancer, so I'm not saying, they should not use it, but there are other options too. There are IUDs, condom, other ways to get around it too, but it's never been shown that birth control pills cause breast cancer either.
Yeah, the same thing, like, as women, we go through so much, but then you see the men and nothing wrong with them, like, they complain about everything.
Yeah, well, I tell my husband, I'm like, you guys only go through one thing. It's pretty much puberty. We go through, childbirth, breastfeeding, perimenopause, menopause, all these different big transitions in our life. Puberty, you get one. We have a whole bunch of other things. And so I think we're used to adapting and having to change and stuff like that just because we have to,
And same thing, like if you have a male doctor, the lack of knowledge is so little.
I can give you some recommendations.
Yeah, we had a great talk with Dr. Falk, who was amazing.
Yeah, he's great.
He came and did some pelvic floor, and he was on point. I mean, he was fantastic. So there are some male doctors out there that do know it. But yeah.
Yeah, when you're looking at your network, you're like, kind of like have to go through 2 or 3 in order to find the right one.
Sure.
With the vaginal estrogen, I'm going through breast cancer, and I'm on year 1 of 5 of suppressing everything. But with this, I think my biggest thing is my joint pain has been out of control. This vaginal estrogen, that wouldn't help with anything like that, would it? It would, kind
because
of.
it's not systemic. It doesn't help with the brain fog or joint pain or anything like that. I mean, you can try supplements, creatine and turmeric and whatnot, but
Okay. Yeah, I kind of figured that, but I thought I would ask.
Yeah, absolutely.
Do you have any thoughts on creatine and those with cancer? Because I've kind of seen all kinds of different research.
I haven't seen anything. I mean, with so the 5 grams a day is recommended, I think, in everyone for, soreness, recovery, those kind of things. They're looking currently for brain health, decreased risk for Alzheimer's and other more long-term longevity parameters, but that's on 20 grams, 15 grams, really high.
Yeah.
But I haven't seen anything yet that I'm willing
No
to
correlation to any type of cancer yet or anything like that.
And the systemic estrogen, the cutoff for when you can start taking that?
So that's changed too. And so previously we'd say 10 years after menopause, sorry, you're not a candidate, and that has changed. And so nowadays when I see women who are in their 60s or even 70s, I'm like, okay, let's look at your risk factors and see. And so the biggest concern is that if you already have existing cardiovascular disease, atherosclerosis, you probably have plaque in your coronary vessels. The concern is that estrogen can actually push those plaques, destabilize it, and increase your risk for a heart attack. That being said, but you still have to worry about your bone health, your gut health, your brain, like all these other things. So what I tell patients is, I'm going to look at your lipid panel and your cardiovascular, I do a calcium CT score. If your score is low and you don't have a bunch of other risk factors, I'll put you on it, and I talk to cardiologists, neurologists, oncologists all the time, and they're shockingly not opposed to it. As long as you get I've even had a couple patients with heart attacks at young ages whose calcium CT score is very high, 300, whose lipid, I'm like, if you optimize everything else, they're actually okay with it. They know it's a risk benefit thing, but for a lot of women, it's more beneficial. Not every woman, but it can be. So it doesn't mean because if you're over 60, you're not a candidate. We just have to look at different factors.
But once you start it, then you have to have it for the rest of your life.
Well, so the interesting thing is, particularly for bone health, when you stop it, you lose those bone benefits within 1 year. It's pretty dramatic. Yeah, it's really dramatic. And so, so impact training, which is jump training, there's two really good sources. They're both orthopedic surgeons. One is Vonda Wright and the other is Jocelyn Whitstein. They both have Instagram sites. Jump training or impact training teaches you, hard surface, hitting, either doing hill bounces or jumping and then jumping on a flat surface, 8 inches like a step. That's all you need. That will improve your bone density by about 1% in 8 months. The Lift More study, which is a study on perimenopausal women with osteoporosis, osteopenia, it was a small study, but it showed that after twice weekly 30-minute sessions with a trainer, women gain bone about 3% in 8 months. Significant. With hormone therapy, it's 3 to 5% in 3 years. With bone resorptive agents like, Prolia and things like that, the injectables, it's more like up to 7%. But the bone is different bone. It's a higher rate of fracture of your femurs, osteonecrosis of the jaw, so it's different. So I tell patients, if you can avoid those, that's your best bet. And one of your best bets, doing impact training exercise is definitely going to help, and that's what you should be doing if you're not on hormones, but you're here, so you're doing it. But hormones are complementary to that too. So you can still benefit, but the interesting thing is the loss of the gains is pretty quick once you stop. So that's why it's changed. We don't recommend at 60 you stop anymore.
Any other questions, guys? Ladies? Thank you so much, Staci.
Sure.
Thank you. This was really good. Yeah, very good. Thank you for being here, you guys.
Thank you.
On your Saturday.
I'm gonna do it again.
So I only do
This I found out. This is Erin Conrad or Con.
Thank
Dread.
you. Okay.
I have, and I need to go back because when I went for pain after like radiation, and I feel like my pain was just too all over the place.